Good evening, everyone. Associate working under Dr. Patta Radhakrishna, sir. I'm here to present a case on walled-off pancreatic necrosis. A 52-year-old female presented with complaints of upper abdomen and back pain on 6th of September 2023. She had no complaints of fever, nausea, vomiting, abdomen distension, features of jaundice, bowel or bladder disturbances. She had history. She was admitted in Tirupati. The was afebrile. It was 94 beats per minute. Blood pressure was 130/70 millimeter of mercury. Perabdominal examination was soft with epigastric tenderness. Her complete blood count showed 15,000 cells per cubic millimeter. LFTs were normal. Serum amylase was 2,137 and serum lipase was 803. September 2023, which showed a pancreas with peripancreatic fat stranding fluid adjacent to the tail region, partially distended. She was diagnosed with acute pancreatitis and was managed with IV antibiotics, analgesics, and PPI. Patient improved symptomatically and was discharged on 9th of September 2023. In the third week after the onset of symptoms, she again developed complete pain and pain after food intake and was associated with abdominal discomfort and bloating. She was evaluated in the same hospital. Her blood investigations showed a normal CBC and amylase was 882 units per liter. A CT abdomen was done on 25th of September 2023, which showed a rim enhancing thin of size 8 x 8.5 x 5 centimeter, volume of 150 ml in the intrapancreatic head and body region, 100 ml in the lesser sac, and 40 ml in the anterior pararenal space. And all the three collections were intercommunicating. A small collection was seen adjacent to the pancreas, measuring of volume 10 ml. These are her CT images. She was diagnosed to have acute pancreatitis with pancreatic pseudocyst. She was referred for endoscopic drainage of the pancreatic pseudocyst. She was managed. She was initially admitted under the medical gastroenterology.
Ubal, I mean, since you are moderating this patient, is 3 and what are the symptoms now?
Now she had complaints of pain in the epigastrium, right hypochondrium.
Yeah. Now, actually been referred for endoscopic intervention. So, do you think that is right?
Third week I would wait, and plus it is there are multiple collections, all are intrapancreatic, and so I think there is no indication for any intervention at this point of time, any mode.
It is an acute peripancreatic collection. It's still not in mature. You can't see even a wall there, not clearly a wall. So I think we can wait.
All pancreatic collection doesn't mean an intervention.
So 3 weeks, sir. 3 weeks, definitely no need for any intervention because it's just evolving. The collection is evolving. Mostly it might turn out into a walled-off necrosis. Because right now there is no features of sepsis. She was having only pain abdomen. Yeah. She's not vomiting. Yeah.
Good. Definition is not 4 weeks and all. But severe symptomatic means you can do. Yeah, that depends.
As Ubal was saying earlier, I mean, do you think you return this infection?
If you see, these are the areas where most of the youngsters should know that when to intervene. See, this is the time if you intervene, you are producing more complication. Frankly speaking, you introduce infection and it is going to be very difficult to manage. So, mostly, what are the fluid collection in the early period of time, you delay. Whatever, whether the endoscopy into percutaneous or whatever the mode, you delay as much as possible. You manage with, even if they develop fever, do a culture. Maybe you can aspirate and do only for a culture. Don't do anything more, or you start an empirical antibiotic. Buy more time. See, basically, if the patient is doing well, buy more time, and however much you take your time to mature these collections, you achieve a good result. If somebody referred for a cystogastrostomy or intervention, don't do that. This is the time you have to wait. So I strongly advocate you wait at least 6 to 7 weeks.
Yes, academically, textbook wise, yes. But what we do, we go for percutaneous transgastric drainage actually.
No, so I strongly feel third week, no intervention.
So it's still acute necrotic collections, no, ANC, it's still, but FNAC is slowly going out of practice now, because just to diagnose infection, like I said, no, if there is rising white cell count, fever, procal, or clinical deterioration, you use any reason to give antibiotics, of course blood culture, just to prove infection, they say many of the units have stopped doing it.
No, but you agree with Ubal that no intervention?
Yeah,
this
this
Okay.
is nutrition support, I think, because she is having pain after eating, so we need to address the nutrition support, nasogastric or nasojejunal tube, ID involvement, empirical antibiotic, just sit tight and don't do anything. So like Vadivel says, no, don't pluck any nail at this time.
You agree with the antibiotic and ID at this juncture, when there is no fever and no any?
I'm not sure about antibiotics, but I agree with every word of Ubal. Every word I agree. There is no need for any intervention. If you intervene, you are producing more harm.
I said antibiotic only when you suspect.
She was referred to SIMS and she was admitted under MGE. On admission, she had low-grade fever, pulse rate was 94 and blood pressure was 120/70. Per abdominal examination revealed tenderness in the epigastrium and right hypochondrium. Her blood investigations were normal. A CT abdomen was repeated in SIMS on 25th of September 2023. It showed a multiloculated thick-walled hypodense collection with few debris, approximately 10 cross 7 cross 18 centimeters, noted at the head and uncinate process, proximal body of pancreas, extending along the paraduodenal region laterally, anteriorly displacing the lesser curvature of the stomach, and inferiorly extending along the right anterior pararenal fascia. It also showed another small loculated collection of size 3 cross 3 centimeter adjacent to the tail of the pancreas, bulky pancreas with significant fat stranding and gallbladder sludge. The CT images, the pancreatic pseudocyst and the gallbladder sludge. She was kept NBM and was started on IV fluids at 100 ml per hour. She was started on injection piperacillin tazobactam. PPN was also started. Endoscopic ultrasound guided drainage of the pancreatic pseudocyst was attempted on 27th of September 2023. A large pseudocyst with some internal echoes was noted. Cyst was punctured with a 19 gauge needle and dilated progressively with a 6 French cystotome and then a 10 French cystotome. A large amount of cyst fluid was drained. A 10 French double pigtail stent was placed over the guide wire, but it came out during deployment and could not be reinserted. An attempt was made to puncture the cyst at a different place, but the guide wire slipped out after introducing the 10 French cystotome.
Piruma, any comment here? Why this happened?
Sometimes, one, I would be worried about the wall. That is one. I think there was a wall. It was kind of getting near the stomach that was there. But the reason why it's always, sometimes you have to work very in close coordination with your assistant. Sometimes when we exchange accessories, sometimes they are not very careful, you may end up doing that. The other thing is, if we work in a certain angle, it is not like a straight endoscope. The oblique view is sometimes a little difficult for people who are not used to it. So if they overzealously push the guide wire as we exchange, the entire guide wire may actually coil up into the stomach, and whatever has gone into the cyst may also slip into the stomach, and that is what possibly would have been the problem here.
So obviously you can't reinsert because there's no cyst you can make out at this juncture.
Depends on how quickly it is drained.
Yeah. Vasu?
This This can happen to anyone, sir.
But third week of thing, US stated putting a plastic stent, I am not very happy because this amount of necrosis will be more than the fluid. So the pseudo drainage of third week, it is not addressed with the plastic stent. It should not be done. So we are creating a more infection. These kind of patients will need more and more sittings. If at all anything can be done, this is the time where they can do a kind of necrosectomy. They can put a metal stent and do a necrosectomy.
Choice of plastic stent is...
Ubal, now Shankar was emphasizing on the point of MDT for this sort of pathologies. When do you involve a surgeon? And if it's your patient, would you bring in a surgeon? Put your hand on your heart and say.
We all.
Really?
I agree with Ubal, and I think Anand also agrees.
Because anyway, in the
human
place,
opposing metal stent would have been a better.
in the place where I had worked for this many years.
Like if you are going to drain because of the fever.
See, go back on the CT, you'll see that the wall was there only on the top floor.
Yeah, but I think that's a great take-home message of just like you deal with malignancy in a multidisciplinary team. I think this sort of acute pancreatic sequelae should be no, because all three of us were dealing with patients when patients become sick, or the endoscopy failed or some complication happened. Only then till that time we don't know what is happening. You agree, Magnus?
No, had you been informed, assuming that the surgical team had already been informed, would you have stopped the physician from doing this US? இல்லப்பா ராதா ஒன்றும் இல்லை அசியூமிங் தட் உன்னை முதலே கூப்பிட்றாங்க என்ன பண்ணியிருப்பீங்க நீங்கள்?
I will tell you why, because as we go on, then see, this is not talking less of anyone, but there are so many other issues involved. I'll come to it.
The first image is when the pigtail stent was placed and it came out during deployment. The second image is the EOS, which shows a collapsed cavity. As the EOS guided drainage of the cyst failed, an ultrasound guided pigtail drainage of the retrogastric pseudocyst was done on 28th of September, the very next day. A 12 French pigtail catheter was inserted into the retrogastric pseudocyst, and free flow of greyish brown colored fluid was noted. Approximately 150 ml of cyst fluid was drained immediately and was advised continuous drainage. The fluid was sent for culture sensitivity and drain fluid amylase and lipase.
Again, was this necessary or would you do? Ubal?
No, sir. Once they intervene, you have to do something. So, because obviously they introduce an infection and we should drain. Otherwise, they land up with the complications.
All the three were
Separate.
separate. All the three separate. இது வேற
இல்லை ஹரி என்னன்னா patient had communicating cysts which got decompressed on stenting, and reinsertion was not possible, but it is got recollected now. Now you have an option that patient is symptomatic, so you could do you have something to go into.
No, sir. When radiologist can do a percutaneous transgastric drainage, why can't a US guided?
What is the gap between the US or the slipped stent to this one?
Not even a day, sir.
1 day. There's a technical issue. Right, okay.
Regarding the drainage, there is no hard and fast rule. The third week, patient has severe pain. If you don't drain, it will rupture and cause ascites. That's the problem.
Rupture to the duodenum can be spontaneously resolved.
That's the problem. Rupture the petrol cavity is a problem.
That is immaterial, but what I am saying is you did not do intervention because
That's what they might pain, but you can assess severe pain, the rupture.
Drain fluid amylase was more than 38,000 and drain fluid lipase was more than 66,000 units. On 30th of September, which is 2 days after the pigtail drainage, she was started on liquid diet, which was tolerated well. Hence, she was given fat-free. Significant peripancreatic fat standing was noted. Interval reduction in the multiloculated thick wall hypodense collection with few debris, approximately 3.5 cross 7 cross 10 cm in the head, ancillary process and proximal body of the pancreas. Another collection of 2 cross 2 cm was noted adjacent to the brain of the pancreas. Brain tube in situ was at the tip of the catheter in the body of the pancreas. Symptomatically better, and she was discharged on 6th of October 2023 with pigtail in situ. She was advised fat-free diet and was advised to monitor the drain output daily. 3 days after discharge, which is in the 5th week after the onset of symptoms, patient came back to us with complaints of epigastric pain and back pain for 1 day and complaints of high-grade fever of 1 or 2 degree Fahrenheit for 1 day.
See, I mean, when patient has a percutaneous drainage, there was some discussion that you will not send the patient home. Is that an acceptable thing, or patients can go home with a percutaneous drainage comfortably? Yes or no? No. Why no? I mean, interesting to.
Just after percutaneous drainage, we can't send them home, sir.
When will you be comfortable that, okay, now, because, a lot of times we send patients abdominal drains after an abdominal surgery. We are not worried, but why are you worried in this patient?
There is necrosis, so there is always chance of block. So it's always to.
I think there is some point in what he says, because unlike the abdominal drains which we keep for a while, these can get into trouble. And especially if this patient is from Tirupati and going home and coming, it's a bit of an issue. Because very often we have seen that whenever patient had, a tube into some necrosum and some pus coming out, something or other is going to happen. It's not that they'll come after 1 month and you take the drain off. It doesn't happen. Yeah, Sendil?
Actually, I disagree because the drain will be there for a long time. Though we used to send patients home and we used to teach attendants how to daily irrigate with 10 ml, 20 ml so that the block will not.
But can attendants irrigate the pancreatic thing? Isn't that a risky thing?
Not irrigating, keep the drain patterned.
Because.
So patient, we have to have close contact. We have to give any phone number to contact if he develop any symptom. We have to advise him to come to OPD or emergency if anything happens. Sir, actually, practically this drain, pseudoaneurysm is a worry, but otherwise there is cost involvement actually. We cannot keep the patient long. So we have kept drain for 3 months. Pseudoaneurysm is not a rule. There is always micro pseudoaneurysm in the wall of the all pseudocyst or necrotic cavity. But large pseudoaneurysm causing bleeding, we haven't uncovered after sending patient. In hospital, immediately after necrosectomy, we have encountered that problem. But we have sent many patients with drains.
No, but as he says, in the immediate intervention, you can't just, if we are sure imaging-wise, clinically, patient is okay, then that's fine. But otherwise.
Going home depends upon how far the patient's home is from the
Yeah, I mean, Tirupati is a bit of a dicey thing. Okay.
On examination, she had low-grade fever and mild tachycardia. Per abdominal examination the abdomen was diffusely tender and pigtail catheter was in situ. She was kept NBM and started on IV fluids. CBC and serum electrolytes were done, which was normal. Her fluid cultures, which were sent for culture, post percutaneous drainage grew Candida glabrata. ID opinion was taken and a repeat fluid culture was sent, and she was started on injection meropenem and levoflox. A CT abdomen was repeated on 10th of October 2023, which showed interval reduction in the thick-walled collection, size of 4.6 cross 7.2 cross 9.6 centimeters. Another collection which was 2 cross 2 centimeters in the tail region. Drain tube was in situ. The CT abdomen with the pigtail inside the body of the pancreas. She underwent ERCP, sphincterotomy and NJ tube placement on 12th of October. Ampulla was normal, pancreatic duct was cannulated and a guide wire was inserted which went into a cavity. Aspiration showed a small amount of colorless fluid which was sent for culture sensitivity. Injection of small amount of contrast did not clearly opacify any of the pancreatic duct. Pancreatic sphincterotomy was done, stenting was not done. EUS viewing showed thick fluid in an irregular pancreatic collection with floating debris. NG tube was placed.
Now here, what is this for, and is there any scientific basis for this intervention? Pardon?
Possibly they attempted a transpapillary drainage.
No, but is this accessible, or is this a convention? Because I'm little worried of how pancreatic sphincterotomy is going to help this patient without a stent in C2. Well, your comment on this?
I'm not sure. Indication for ERCP, these early sittings is only to us. Parama said any small collection communicating with the PD, we can drain. Or if any pancreatic leaks, we can bridge across. That is only two indication in a case of 4 or 5 weeks of pancreatitis. And I don't think it is really indicated in this scenario. Because what is the indication, we don't know.
Will it cause more damage to the patient than benefit?
Already the pancreas is gone. It may not cause more damage.
There's no organ there. So, I don't think you get any benefit out of doing this ERCP, or unless you're going to introduce infection, there's no factor doing it. There's no indication.
She was started on NG feeds at 30 ml per hour the same day. SG opinion was taken on 13th of October for cystogastrostomy. After obtaining anesthetist fitness, she underwent laparoscopic cholecystectomy, open cystogastrostomy, and pancreatic necrosectomy on 14th of October.
Because patient is not stent in symptomatic, and some kind of symptomatic is done and not becoming better, and that's when we were called in saying that if you can do something about it. Because our major issue is unlike all what you've seen in the previous, when this is onto the left side, this is onto the right side, and the stomach lumen is almost completely occluded. Nutrition has become a problem.
Anterior gastrotomy was performed using harmonic scalpel. Posterior gastrotomy was also performed. Using an aspiration needle, an attempt was made to aspirate the cyst laparoscopically. As it was not possible, a midline incision of 5 centimeters was taken. Pancreatic necrosectomy was done. The cyst wall was sutured to the posterior gastric wall using 2-0 vicryl. Anterior gastrotomy was closed in 2 layers using 2-0 vicryl and 2-0 Mersilk. Drain was kept. She withstood the procedure well. The cyst fluid and pancreatic necrosome were sent for culture sensitivity. An image of pancreatic necrosectomy. On post-operative day 1, NG feeds were restarted at 30 ml per hour. Her drain output was 10 ml serosanguinous in nature. On day 2, the drain was 20 ml serosanguinous in nature, and around 3:45 p.m., she developed fever, high-grade fever with chills, for which a CT abdomen was done. No significant changes. On day 3, NJ tube was removed, and she was started on clear liquids at 30 ml per hour. Drain was 30 ml serosanguinous in nature. The cultures which were sent during surgery, it grew carbapenem-resistant Aeromonas punctata and Candida tropicalis. ID opinion was taken and antibiotics were escalated to minocycline and fluconazole. On day 4, the diet was escalated to full liquids. Drain was 20 ml serosanguinous in nature, hence it was removed. Post drain removal, she had persistent discharge from the drain side, so a colo bag was applied to the drain side. The next day, the drain output increased to 150 ml. On day 5, overnight, she had low-grade fever spikes. On day 6, the wound showed mucopurulent discharge. Wound irrigation was done. Drain was 115 ml serosanguinous in nature. On day 7, the drain output increased to 300 ml serosanguinous in nature. A drain fluid amylase was sent, which was more than 63,000. On day 8, the wound was examined and was found to have gastric content discharge. A colo bag was applied to the suture line. She was kept NBM and was started on IV fluids. RT aspiration was also advised. Images of gastric content from the suture line. On day 9, a C line was inserted and she was started on TPN at 30 ml per hour, which was increased according to her caloric requirement. Injection octreotide was also started. The drain side, it was 25 ml, and so from the suture line it was 40 ml, which is brown in color. She continued to have persistent low-grade fever spikes. ID opinion was sought, and the antibiotics were escalated to tigecycline. The same day, she also had an episode of desaturation. Her saturation was 88% in room air, and she was started on O2 supplementation via face mask. On day 10, she continued to have low-grade fever. TPN was escalated to 50 ml per hour. From the drain side, it was 100 ml, and suture line, it was 50 ml. In view of persistent gastric content discharge from the suture line, a CT abdomen with oral contrast was done. On administration of oral contrast, the stomach and the small bowel loops up to mid-jejunal loops were opacified. Active extravasation along the posterior wall at the pyloric region with opacification of hypodense collection at the head uncinate process and proximal body of pancreas, with caudal extension along the paraduodenal space, reaching up to the anterior pararenal fascia on the right side and laterally extending to the gallbladder fossa, and 2 tracts of contrast opacification from the gallbladder fossa, one extending transcutaneously at 12 o'clock position, which was getting collected into the colo bag which was applied to the suture line, and another at 10 o'clock position, which was getting collected into the colo bag which was applied to the drain site. You could actually see the contrast getting collected into the colo bags over the suture line and the drain site.
Now here in short, there is cystogastroscopy. The cyst was leaking. That is coming from here. The anterior wall is leaking, it's coming from. So there are 2 areas of leak, one behind and one anteriorly.
She was planned for NJ tube placement on between day 11 and day 14 postoperatively, as the gastric content discharge was minimal from the suture line. NJ tube placement was withheld. As she had desaturation episodes, a chest X-ray was done which showed right pleural effusion. Pulmonologist's opinion was taken and she underwent an ultrasound guided right pleural tapping. Pleural fluid was sent for amylase, glucose, LDH and protein. The following are the values. The chest X-ray showing right pleural effusion. On day from postoperative day 15, the gastric content discharge from the suture line was very minimal. So on day 16, RT was removed. Day 17, she was started on clear liquids, which was tolerated well and was escalated to soft solids gradually on day 21. Patient was discharged on postoperative day 21, which is on 4th of November. She was afebrile, ambulating well. She was tolerating soft solid diets and was passing stools normally. There was no discharge from the suture line, and from the drain site it was 5 ml. Coming to the nutrition part of this patient, during the first admission in SIMS, she was started on peripheral parenteral nutrition, which from which she didn't even meet around approximately 50% of her caloric and protein requirements. This chart is post-surgery from post-operative day 1 until she got discharged. She was on NJ feeds for like three days post-surgery, and then NJ feeds were stopped.
Basu, you're asking about management. Just go to the previous slide. If you see the percentage caloric requirement is 0 to 36%, and it's whatever it is, when the patient was on the medical side, the nutrition is very, very suboptimal. If you see that, then move over next slide. Now when it came to the surgical thing, now that is 100% there. Our people keep on wondering every morning whether the protein requirement was met with, whether the caloric requirement. These girls are very, very persistent. If it is not there, then they'll get back to the dietitians. That's some subtle difference in the nutrition part of it. It will definitely have an effect on how the patient heals subsequently, but you're asking me as to, why should people be involved from the beginning, and how, because if we are involved from the beginning, we look into all these things. Well, I may not, but my people.
Nutrition is not a physician or a surgeon's thing.
It's definitely everybody's domain.
Nutrition, when the patient was
when the point came, why should be MDT from the beginning, these are all things. It's a learning thing for everyone. I don't say we've done some good or somebody has not done. No, just see, this patient actually, when the stomach is leaking anteriorly, posteriorly, nil oral, and for that matter, once when tried NJ, unfortunately, in my experience, I've seen none of the NJs stay for long. It will come up, then you all reinsert again. There are at least twice, thrice. I don't know whether in your experience that happens, but for some,
while you insert, while you're doing endoscopy itself, half the time it comes up.
I don't know why. See, NJ is not equivalent to feeding endoscopy. That's one major thing. And we also have seen sometimes when it's coiling up, whatever we give through NJ, it will come through the stomach, into the stomach. It's not exactly is a compartment that this will not go only to jejunum, doesn't come to the stomach. So NJ is still dicey, and NJ always we find it difficult because the patient has to go to the endoscopy room, and sometimes you have to give some IV anesthesia and all that stuff. It's a bit of an issue. So what we did in this patient is, when the stomach is leaking, TPN, nil oral TPN, complete.
See, there are problems with TPN. TPN is not that,
yeah.
You say, no, TPN is not very, very easy. No, it has its own problems. One, infection is tremendous, particularly these people who are malnourished, already having so much of issues, having frequent sepsis, trying to maintain a central line, doing things is even more difficult.
It is, undoubtedly, but this is the patient de-indication, where, we can't use the stomach.
Nothing like, if you can organize a feeding jejunostomy, as long as you can, sometimes there are people who have tried doing it on the bedside itself because the patient was so sick. They can try to put a small nick, get a loop of jejunum, do a feeding jejunostomy. That's the best.
Take it, yeah.
And to summarize, the onset of symptoms was on 6th of September. She was admitted for 3 days and discharged on 9th of September. After like 17 days, she had her second onset of symptoms. She was referred to SIMS. EUS guided drainage was tried but failed. As it failed, she underwent percutaneous drainage. Patient improved symptomatically and she was discharged. 3 days post-discharge, she was readmitted. NJ tube was placed on 12th. Cystogastrostomy was performed on 14th. She developed gastrocutaneous fistula on the 8th post-operative day, which is 23rd. TPN was started. As the fistula's output was low, we started her on orals and subsequently increased it to liquids and then soft solids. And then she was discharged on 4th of November. This is the first OP follow-up. She had no specific complaints and the drain side discharge was nil. Suture line, it was approximately 2 ml per day, which was brown in color. During the recent follow-up, she did not have any specific complaints. Her appetite was normal, and she's passing stools normally. On examination, the scar was healthy, and there was no any active discharge from the suture line or the drain sites.
Radha, my only question is that, as a surgeon, you got involved later. See, could everything been avoided had they not gone in?
No, I don't say that. I don't say that, but I feel, as Shankar has rightly put at the beginning itself, these patients, acute pancreatitis, if they, majority of them, have one attack and then they're never seen, they're okay. But when we see that in the beginning itself, that this patient is likely to get into trouble, that's when a surgeon should be involved also.
See, what sort of things that you anticipate where you should be involved first along with the physician? Like, there are mild attacks of interstitial pancreatitis where, we don't call the surgeons. But then, like this means, what sort of patients that you want the surgeons to be there?
Majority are very, very minor pancreatitis, and they may do ultrasound, may not do, even ultrasound may not be necessary to diagnose pancreatitis. But the ones who would like to have you'd like to do a CT, who are not that simple, when you have a baseline CT and you can make out from the CT that this patient is likely to develop problems in terms of fluid collection and, pseudocysts.
Does the CT score tell you anything that you should...
Yes. Now, whenever, see, because a number of times in our experience, when we go down to the radiology section, suddenly we'll see a lot of these CTs been discussed by the previous team. The radiologist will say, have you seen this? I said, which patient? I mean, we'll see at least 10 patients per day, like that, which is never, we are not involved in, since, which is not a very healthy situation, because a lot of these patients may not require so many interventions which are not in, and definitely together I think patients will do better.
I agree with you. The best way is then in any attack of pancreatitis, be it mild or moderate or severe,
if that is,
bring everything to a
that'd be a great thing.
No, you bring it to MDT, that way you don't miss anything.
Yeah.
Rather than saying
I
that
think that's a take-home point. See, I mean, the fear shouldn't be there that if a surgeon is called, he'll operate. Not true. Especially in pancreas-related issues, we hesitate to operate. And majority of the times we don't operate, patients become all right.
No, it may not be really just because you want to operate or anything like that. I think sometimes the physicians get carried away by the thinking that they can manage and there may not be needing any intervention. I think that is, we may call a physician's overconfidence or something. But then, traditionally, in UK, they admit all the pancreatitis only under the surgeons, not under the physicians.
Yeah. Actually, this was told by Dr. G.V. Rao from Asian Institute of Gastroenterology. See, it's easily that you can label pseudocyst as a walled-off necrosis and vice versa. Suppose you label walled-off necrosis as pseudocyst, your endoscopic results will be excellent because there is no necrosis. On the vice versa, if it's more of a walled-off necrosis, the endoscopic results may be suboptimal. Even surgical results may be. So what they found was when the medical gastroenterologists are taking the decisions themselves without involving the surgeons, doing endoscopic treatment for walled-off necrosis, the results are very poor. This was told by Dr. G.V. Rao, and subsequently only they decided that they will have a combined meeting. So to answer your question, not all pancreatitis needs to be discussed. Any pancreatitis which has necrosis, necrotizing pancreatitis, I think deserves to be discussed.
That's what the other way to say, as I told you, in UK they admit all the pancreatitis under the surgeons just to make sure that they all...
Sir, the problem is in a Mayo clinic, a surgeon and a gastroenterologist think alike. If you give a situation, the treatment option, if you ask them, both will be same. But here we have diverse opinions. So that individual bias has to be...
that will only come if you have a multidisciplinary approach.
I'm telling you.
Like, there are things like, there are people who have a pancreatic ward in a university hospital and things, where you have got different range of cases from acute pancreatitis to chronic pancreatitis to all sorts of complications. There is only a combined rounds with a gastroenterologist, surgeon, nutritionist, everything, everybody together go for a rounds. That's how some cases are managed. So I think irrespective, the best way to manage is that not to, this thing is put everything through MDT, irrespective of the nature, then you will always be successful with
that the MDT should have an ID, should have a dietitian as well from the beginning. As you see, all these people have dietary issues.
So one more, one more role for surgeon referral is mild moderate pancreatitis. Before discharge, they have to, biliary pancreatitis, we need to do cholecystectomy before discharge.
Radiologist is definitely a part of it because they only know what's happening actually. With the repeat images, they can very quickly make out that between the previous image and this image, there is some change, which we may not make out very well, they will.
You saw the problem with gastrostomy.
No, we're all eagerly waiting to see how Pirma does it.
What not to do and what to do.
How I do it.
Thank you. I think this will be the last session, so it will only be a very small video. It runs probably about 2 minutes. This is how to do a EUS guided cystogastrostomy. Hopefully this plays. In EUS guided cystogastrostomy, there are only 3 principal steps that we look at. One is to puncture the cyst. The second step, and introduce your guide wire. That will be the lifeline. The second step is to dilate the tract so that we can deploy the stent, which is the third step. So this you see is predominantly I would say it's still a walled off necrosis if you look at the entire cyst, but I think majority of it is still there. You can see a small amount of necrotic content at the end. So technically it's a walled off necrosis, but probably less than 10% of it is there. So you see that we have punctured it with a 19 gauge needle. That we are introducing a guide wire into the cyst. All of it is just being monitored under the EUS. We also have a fluoro in the room. And now once we exchange the needle, we leave the guide wire inside, we take off the needle, and over that we use various devices that can be used. One, initially we used to use biliary dilators, blunt dilators, Sohendra biliary dilators. You can use balloons or you can use electrocautery assisted devices. So practically the easiest one to use, or the ones which are much malleable, which will be next to the 19 gauge needle which goes in, is probably a 6 French cystotome. So that's an electrocautery assisted device, so which can go over the guide wire. So this is from the stomach, we're going into the wall. So we've crossed into the cyst wall. Following that, we exchange it over the guide wire. We exchange it with a CRE balloon. Now you can see that the balloon is getting inflated, and this is the cyst wall, and that's an endoscopic view of a balloon dilatation being done after this dilatation with the cystotome. So that's the kind of the orifice that you see from the stomach, from which you can see a fluid coming through. Generally, if we place plastic stents, the recommendation is at least to place 2 stents, and if it is thick, lot of necrotic fluid or pus, also to add another nasocystic drain so that you can irrigate it also. So this was what it used to be earlier, where we had only mainly plastic stents. Generally we use double pigtail stents so that the cyst and the gastric wall are opposing, or at least in contact with each other. But with advent in the last 5 years or so, we have, I don't have the video here, but we have better metal stents which can be placed, which are called as lumen opposing stents. And all this requires, as I told you, we require multiple steps where you have to coordinate very well with your assistant. So puncturing, and every time you exchange, you need to be careful. Otherwise, you may end up leaving the guide wire, or you may end up deploying the stent in the wrong place, where the stent may even migrate into the cyst. So to overcome this, the recent development has been about a hot cautery assisted single step device, where you just puncture, dilate and deploy all within the same setting. So you don't have to exchange the guide wires. So the chance of this problem of guide wire slipping, all that doesn't happen. That is the hot axios stent. I mean, that's a electrocautery assisted device. You can, everything is loaded onto the same device. You puncture, and it dilates the tract, and you deploy the stent all over in just 5 minutes time. So that also gives us a much bigger lumen for us to go in for any subsequent necrosectomy if it is required. I'll just show possibly the same patient, I think also we could do a necrosectomy where we could just get into the, we could dilate, I mean if you replace the plastic stent, the only problem is you have to remove one of the stents, you have to dilate the tract again with a bigger size balloon for your gastroscope to go in, and then you use various accessories to pick out the necrotic content from the cavity. But and then reinsert stents again. So I think that's about it. I think I'll be happy to take questions.
Which patient you will refuse to do endoscopy and
endoscopic drainage?
Endoscopic drainage.
See, the location of the cyst is very important. If it is anything in relation to the stomach or to the duodenum, first part I think, or the second part, in the C loop, I think it is quite amenable for a cystogastrostomy. If I find that most of the cyst or predominantly the cyst is in the paracolic gutter, or only very small extension into the lesser sac, then probably I may not consider doing an endoscopic cystogastrostomy. 2, if the amount of debris is very high, if it is like a predominantly solid or predominantly 60 to 70% of it is like solid necrotic content, my personal bias is possibly surgery might be better off than attempting at endoscopic attempts. Practically, I think even if you have a very large cyst and lot of necrotic content, you need multiple sessions to go in and drain, and I think we find it very difficult to convince the patient to stay in unless very few have very deep pockets to stay in the hospital. If there's a lot of if I find a pseudoaneurysm in place, then immediately I may not. Probably it is better to tackle the pseudoaneurysm first and then consider draining it endoscopically.
Which you metal stent which you placed during necrosectomy?
Supposed to be removed within about 3 to 4 weeks. Beyond that, there is a concern about erosion of this. The distal, the tip of the stent which is in the cavity, which may erode into the opposite wall where you may develop. So the recommendation, if you place a metal stent, is to remove it within 3 to 4 weeks. It is a good, the only advantage of leaving a metal stent in place is that the conduit is pretty good. So it is about, you have 20 millimeter, 16 millimeter size inner diameter through which your scope can go in any number of times you want. The problem is that it can also migrate as the cyst collapses. I mean, it can migrate either way, either into the stomach or it can go into the cyst. But since it's a dumbbell-shaped stent, the chance of it is supposed to be lumen opposing, but sometimes it can migrate still.
Thank you, sir.
Anything else? Thank you.